Okay, hi everyone. Thank you for joining us this evening. Today's tutorial is on delirium and dementia, given by Dr. Dalton. Just a couple of rules before we start. For those of you watching via the Zoom, if you have any questions that are relevant to what's being covered in the moment, just pop them into the chat. If you have any questions that can wait till the end, just pop them into the Q&A. If you're watching on the Facebook Live, just comment your questions and we'll make sure that they're passed on. That's all from me. I'll hand over to Dr. Dalton to begin. Thank you.
Cool. Thank you very much. I'm Tom. I think I did a tutorial a few weeks ago on anxiety disorders, and this evening is on dementia and delirium, obviously, which is quite a kind of a dense topic. There's quite a lot of information which you then just need to kind of learn for MCQs for med school purposes. So it can be a little bit dry. I'll make it interactive though, don't worry. And I think, yeah, the main thing is, I guess, just to bear in mind how big and common these two conditions are. I mean, they overlap a lot. So it really is something that you'll be getting to grips with and you'll be very comfortable dealing with by the time you're working as a doctor, particularly delirium. For any hospital doctor, that's such an important topic. And we'll kind of go over why that is. But without further ado, let's crack on. So hopefully you can all see the slides. Please do give me a shout on the chat if you have any troubles seeing or hearing anything. Yeah, if you have any questions, please do ask them as we go along, and I'll kind of pick them up at the end of each slide. So yeah, and I'll be asking you questions as we go along as well. Just a disclaimer from the lovely people at Becoming a Doctor before we begin. Basically, it's all my thoughts rather than anything representing them. So these are our learning objectives for this evening. So we're going to just look at what delirium is. I'm sorry, what dementia is and how it differs from normal aging. And look at some different types of dementia and how they typically present, and that's all kind of stuff that you will need to know for med school finals kind of things. But yeah, it's very useful in practice. And then we'll talk about delirium. And I would say probably that's going to be the most important topic of the evening. So if you pay attention for only a few slides, make it these ones. So firstly, just a quick look at normal aging, because the brain does change as you get older. So I think it's important, and this is an easy thing to ask on an MCQ. What is the sign of normal aging and what's the sign of something going wrong in that process? Dementia, for instance. So I mean, this is just a bunch of facts really, but just to kind of whiz through them. So the brain structure changes as you get older. Basically, there's a global kind of mild shrinkage of the brain, and you lose a bunch of, you gradually lose more and more brain cells, in particularly the cortex and hippocampus and the cerebellum, but kind of across the brain, quite a lot of areas, but these are the particular ones. And obviously that comes with decreasing connectivity, and you do get deposits of tau and amyloid protein. And if you don't kind of know about these two already, they are key to the pathophysiology of Alzheimer's disease, and also to frontotemporal dementia, and the various other dementias as well. But these, well, we'll talk about what these are. But basically, it's useful to remember that you do get deposits of these in normal aging, and so the difference between a neurodegenerative process like Alzheimer's disease and normal aging, there is a definite difference, but actually there's not a complete separation. It's not like the disease process of Alzheimer's is completely unlike what happens in normal aging. It's kind of like it happens a lot worse than normal, if you like. Like many illnesses, like high blood pressure, whatever have you, it's worse than normal, but it's not something completely new that's not there in health. So just some things to be aware of there. And also in brain function, as you might guess. So there is a decline in some particular cognitive functions as you get older, as you might imagine, particularly like cognitive inflexibility. And this can lead to a lot of perhaps anxiety in older people in terms of encountering new problems or things like that, when a young brain is able to take those things kind of in its stride and be flexible and just think your way out of stuff. Whereas I guess if you get older, that just gets a little bit harder. So, I mean, anxiety in older people is quite common, and that could be part of the reason. But yeah, other declines in memory, as you might imagine, and things like problem and a gradual decline in IQ. And the really key thing about normal aging, like I guess is the most important part, which sort of links in with both of these, are the psychosocial changes that come about in normal aging. And these are all kind of self-explanatory and obvious, I guess, but they really are hugely important when you're talking about these illnesses, because, I mean, to an extent, various of these, particularly various kind of other health conditions, and things like just isolation and stress and all of this sort of stuff does seem to contribute to the disease processes of some of these types of dementia. So it's not, it's not just a separate thing that also happens alongside it. It is part of the pathophysiology in some ways. And also just, if you're assessing someone with one of these illnesses, it's never just about assessing the dementia, getting the right diagnosis and starting some tablets. Like, this is so much more important, these psychosocial factors, for improving this person's quality of life, which ultimately is what you're aiming to do. So really keep these in mind. And that, is true of your OSCE stations as well as of real life. But they're absolutely crucial. You can't really just separate the neurodegeneration from the context in which it happens. Okay, so that's normal aging. Quite a brief slide on that. We'll move on to the good stuff, if you like, dementia. I never thought I'd say that. So I guess I sort of hinted at this a moment ago. You can think of dementia as a bit like, you might call it chronic brain failure. And this is in the same way that you get kind of heart failure, kidney failure. Basically, as you get older and older and older, there's an increasing likelihood that some of your organ systems will start to fail for various reasons, but generally there are some particularly common ways in which they tend to start to fail. So I mean, kidney failure, ultimately if we lived indefinitely and nothing else killed, everyone would eventually get kidney failure, for instance, or heart, like eventually every organ system starts to develop dysfunction, and that will usually look a certain way. So kidney failure usually looks a certain way in terms of the physiological test, whatever, and the symptoms it's presenting, blah, 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 all that sort of thing. So dementia is kind of the same, but in the brain. It's that organ system starting to fail, and because of the way it works in health, it tends to fail in a particular way. Just as a result of the normal mechanism of its functioning, that normal mechanism has, I guess, you might say, particular weaknesses or particular bits where over time a problem's likely to start emerging with that thing. So, I mean, the tau amyloid protein, that you get increasing deposits of that. That's just something that the brain does, but actually, as you get older and older, it's more likely to contribute to illness. So I think, thinking of it along the lines of chronic brain failure in the same way that you have other organ failures is a useful way to think of it. But also keeping in mind that it is different to normal aging. Like, you can have, some of your organs might be failing, but others are actually working perfectly fine as you get older. And dementia is like that. You might have various illnesses, but you might have no elements of actual dementia, of brain failure. Anyway, it's a bit of a long-winded way of saying that point. But, oh no, my animations aren't working. That's depressing. Oh, they are again, actually. Okay, sorry. I've been twiddling around with my slides. All I have to do is my computer breaking. So, when we talk about dementia, I'm sure you're all familiar with kind of what it means. It's a progressive decline in certain cognitive functions, various domains, obviously memory, general cognition, problem solving, working memory, executive function, all these sorts of various cognitive domains. I haven't kind of provided an exhaustive list of all the different cognitive domains because it just gets a bit wordy. But, memory is one of the big ones, obviously, as you might imagine. These higher cortical functions. But you also get some other problems along with it. You may or may not get sort of dysfunction in emotional regulation. You might get behavioral symptoms. Sometimes you can get personality change. So it can present in a kind of a varying different ways, depending on where the neuronal loss is heaviest, I guess, and that will just be different from person to person. But by and large, it tends to follow a common pattern. And like any organ failure, it just increases with prevalence with age. So a third of people over the age of 95 will have dementia. It's just very likely to happen. Theoretically, if you kept on living indefinitely, everyone would get dementia, like I said. And then, so here's a question for you. What are some differentials? So, I mean, given that roughly what dementia tends to look like, can you suggest, hopefully you are, the people on the, there are 20 of you on the Zoom call, you're able to access the chat, so just drop in some suggestions of a possible differential for dementia, differential diagnosis. So delirium, excellent, absolutely, and we'll pick up on the reasons why that is different from dementia and how you can tease them apart. Depression, you're absolutely right. Hypothyroidism, all good suggestions. Any others coming in? Or we can zip along. I've covered just some particular ones. So it's a bit of a catch-all. Reversible causes, of which there are quite a handful. And Parkinson's, oh, good question. Yes, so I'll come on to that, whether Parkinson's is kind of comes under the heading of dementia or doesn't it? Wernicke-Korsakoff, excellent. We can chat a little bit about that in a minute. SOL, remind me, not coming back to me what that acronym stands for. So, do drop that in, I forget. Space occupying lesion, of course, sorry. Duh, I'm a psychiatrist, I should know that. I'm a psychiatrist, you just write a lot and you stop using acronyms because you just have loads of time to write everything out in full. Absolutely. So really good suggestions there. So it's important when you see a potential new presentation of dementia to rule out some other causes because your approach is going to be different depending on what they are. Okay, so types of dementia. Right, this is just a bar chart, a pie chart of the most common types. Is anyone going to tell me what is the most common type of dementia, this big orange blob here? It's not a trick question. Alzheimer's, correct. The next biggest one, so ignore this actually, this is a bit of a funny one, so leave that. The next biggest one is kind of both of these. Vascular, absolutely. So is anyone going to have some guesses at these last couple of types of dementia? What's this next most common one? So Lewy body, absolutely. And there's one more kind of reasonably common one that's, I think it's about the third most common, actually I'll double check that when the slide appears. Frontotemporal, you're quite right. Yep, so here we go. So just this confusing little block here is mixed of the two because both of these are just so common. Obviously there's going to be lots of overlap. And then you've got Lewy body, the next most common, and then frontotemporal. So those are kind of the ones to be aware of. And then there are various others that we'll mention. How common is mixed dementia? So there's not actual numbers on this pie chart, which I apologize for. I imported it from a different presentation. I missed out the reference. I mean, I guess I could guess at exactly what that fraction is. It's looking at, I'm going to say maybe about 10%. I would have to look that up and check exactly how common it is. This is really just to get you an idea of the barn door, like what are you most obviously looking for, and you know what are some of the things that you have in the back of your mind that are less common, that sort of thing. I would check perhaps your particular med school curriculums about in terms of whether you do have to know the actual numbers of how common these are. I mean, Alzheimer's dementia is 60, 70 odd % depending on the study. And whether you count kind of mixed picture. So it's sort of that kind of ballpark, which I would imagine is all you really need to know for med school, but you know, check that and by all means learn the exact numbers if you need to. Right, so here's a little quiz for you. Let me get the polling up. Hopefully you have access to that in the Zoom. So I've opened the poll. Which of the following is not a feature of normal aging? So hopefully you should be able to vote. Nobody's voted yet. Okay, good. People are starting to vote. Great. Right. And this is, you know, I've tried not to make these questions too easy. Right. We've got half of you have voted. I'll give you 10 more seconds. 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay. Is ending here, ending here. Right, what have you all voted for? So, hopefully you can all see this. The majority of you have gone for deterioration of emotional regulation, and you are absolutely right. That is the one feature that's a possible feature of dementia. All of the others do happen in normal aging. But, I mean, it's not an easy one, because, as we'll see, these all also happen in dementia, but they happen to a clinically significant extent that's kind of out of the range of normal. And I mean, these are all things that would be quantified in quite specific ways that I haven't gone into. And there are sort of, generally there are sort of cut-off points for what's normal and what's not. But I think the main thing you need to be aware of is these do all happen in normal aging. It's just that, and yeah, it's tricky. There is a spectrum. It's not we can create a cutoff between normal aging and dementia. There isn't really one. It's just where we judge that it's causing a clinically significant problem. But it is, fully blown dementia is definitely different to normal aging. Right, hopefully that's not confused you too much. And yeah, just to say, hippocampus, frontal cortex, and cerebellum were three of the areas where you do get commonly a bit of cell loss in normal aging, because a few of you voted for that, I can see. Right, on we go. So, types of dementia, how they present, and what's the pathophysiology. Okay, so Alzheimer's disease, I'll talk about the pathophysiology on the next slide. I mean, it presents with all the features of dementia that we kind of just talked about, but particularly memory impairment is a really big feature, as you probably know, of Alzheimer's disease. And this makes sense when you look at the particular areas that are affected. So again, I'll talk about the exact pathophysiology on the next slide, but in terms of which parts of the brain are hardest hit, it is this area that we call the entorhinal cortex, and this is the medial temporal lobe. So if you orientate yourself on the scan, the temporal lobe, the sort of bit that comes along the sides here, if you like, I know you probably can't see me doing that, is here, and it's this bit that's sort of, well, entorhinal, it's near the nose, the sort of the nasal cavities, that's why it's called that. And it's these, so here is where you find the hippocampus, and various other important structures. And you can see the extent of the neuronal loss here. I mean, this is pretty advanced dementia that you see in this picture, but there's a lot of global wasting. All of these sulci are much, much bigger, and the gyri are much smaller than in a normal brain. So you can see there's a huge difference here between normal aging and in an Alzheimer's brain. The ventricles are much larger. All of these just point you to cell loss. The brain has shrunk, and it really has massive, like, look, this area is full and it's just basically gone. I think the red one is the hippocampus. I would have to double check that. It gets so kind of shrunk away it becomes hard to see, but that's where you get really, really heavy cell loss in Alzheimer's disease. So, we have a question. That's a neat pause in which I can ask that. Is that an MRI? Yes, it is, I believe, because you can see the differentiation between the white matter and the grey matter. I should have included oh yeah, it is an MRI. I can see in the link at the bottom of the page to that image. Okay, so treatment for Alzheimer's disease. Go. Give me some suggestions. How do you treat this? Support. Good answer. There are several things you can say in answer to this question. I assume you're talking about kind of psychosocial support. Acetylcholinesterase inhibitors, marvelous. Aricept is one of those, excellent. Any other thoughts? I mean, that's pretty good, to be fair. Another group of drugs is the NMDA receptor agonists. But yes, the main ones are acetylcholinesterase inhibitors. Now, can someone tell me something really important about, this is a bit of a read the examiner's mind kind of question. There's if you were starting someone on acetylcholinesterase inhibitors, and you telling them, what does this drug do? What key thing might you want to mention? Give me a few things, and hopefully one of you will get the one that I'm thinking of. You might well mention side effects, although actually they're quite well tolerated. You get a bit of nausea with them generally, but they don't have very many side effects. But in terms of what they do, great, perfect. So Emma suggests it slows progression. Well, yes, and it's sort of mixed evidence on whether it slows the progression. Basically, if you think of a line, I'll mime in the air, but if you can see me, you can. If you think of a line of the slope of the cognitive deterioration in dementia, I should have drawn this on the slide, that would have made it easier. If you are taking acetylcholinesterase inhibitors or NMDA antagonists, you will follow a parallel line, but it'll be slightly offset. So basically, if you are experiencing symptoms of dementia, you start taking one of these, your symptoms will improve. But once they've improved, they'll kind of plateau, and then they will continue to deteriorate. And another important thing, you can see my screen, great. Another important thing is that if you stop taking them, you then go back to exactly where you would have been if you'd never taken them. So they're not disease modifying. that is basically the key word. They're not disease modifying. They improve the symptoms, but they're not disease modifying. They don't actually affect the progression of the disease, like the pathophysiology. They just improve the symptoms. There is sort of mixed evidence that they slow it a little bit, but I guess the main thing is they're kind of treating the symptoms, but not under the underlying disease really as such. So, good to know. And I mean, yeah, at med school level, I'm not sure you have to know a great deal more about these other than that. Cause a bit of nausea, but quite well tolerated. You take rivaroxaban twice a day. I don't know if I need to know that. I don't think you do. Right, so that's the treatment. Now, the pathophysiology, I can never say that word, of Alzheimer's dementia. Kind of two things, which you're probably aware of. It's tau protein, it's amyloid. So tau protein is a little protein that stabilizes microtubules, which are part of the the internal architecture of the neuronal cells. For the microtubules transport stuff from one end of the cell to the other. They're basically, I don't know, you probably remember this from second year. I won't bore you with it, but they're in all the cells, and they are important in transporting stuff from one bit of the cell to the other and kind of holding the cell together in the cell structure. And they themselves are stabilized with tau protein, so it's just a thing that's in the normal brain. And what you tend to see in, in normal aging, but to a very abnormal extent in Alzheimer's disease, is that the tau proteins, there's a buildup of them. They clump together and they aggregate to form these blocks, which, if you see these little flame-shaped marks here, that is a cell body. So that shape that you can see there, that's a cell body that's completely packed with tau protein and has therefore died. So that's kind of one of the main mechanisms of neuronal cell loss in Alzheimer's. And in terms of exactly why it happens, there are lots of very interesting theories to do with neuronal cells that are meant to have come out of the cell reproduction cycle and have kind of slightly gone back into it in an abnormal way, or to do with oxidative stress, or various things. There's a lot of interesting stuff and a lot of interesting research obviously going into exactly why this happens, but I probably don't have time to go into much depth with it today. You get the buildup of tau proteins. That's what you need to know. You also get the buildup of amyloid. And this was kind of, in terms of the theory of what we noticed, what we learned about Alzheimer's disease as we've gone along over the years. Amyloid for a while was kind of the big one. We thought that was the main process. And amyloid is just another, it's an extracellular protein, and it builds up in huge plaques that again cause cell death, and they cause inflammation, and there's all sorts of vascular things that happen with that as well. But yeah, you get these build-up of proteins, basically. And tau seems to be the more important one, but there's debate about this. And it's lots of interesting things that we could talk about there. I'll kind of leave it there. That's the main bits you need to know. But if you have any kind of particular questions about the pathophysiology, feel free to ask them and I will do my best. Right, moving on, vascular dementia. So what can you tell me roughly about vascular dementia? Just give me a couple of things about how it might present and what's the pathophysiology is mainly what I guess I'd like to know. More sudden onset? Yes. Can you qualify that perhaps with a detail about how the course of it typically progresses? You're not wrong. I mean, yeah, you're definitely not wrong. That's correct. But okay, so we've got a few comments about the pathophysiology as well. Stepwise deterioration. Perfect. That's exactly the phrase I was looking for. Yes, and so obviously it is sudden onset, but it's kind of lots of sudden little steps. And yeah, it's ischemic changes. It's basically, you know, loads and loads of tiny little strokes. That's basically what it is. And often you might have slightly larger strokes that are kind of noticed. You might have a TIA, or the symptoms lasting less than 24 hours, a sort of a mini stroke as it's called. But then after that, you don't quite return to your normal baseline. And it's sort of that stepwise. Or it might just be steps where there's not an obvious TIA or stroke, but it just sort of steps down relatively suddenly, and then you plateau in between those. So you're absolutely right. And in terms of lack of oxygen to the brain, as someone suggested, yeah, because it's a stroke, it's an usually sort of embolic event, and it blocks off blood supply to a small area. And this is what you can see on the scan. There's a little ischemic, basically, yeah, bits of ischemia where the white matter has died in that area. So, yeah, it's multi-infarct is another way to define it, stepwise, and yeah, In terms of the risk factors that cause it, it's very much the same as stroke and heart disease. So it's the vascular risk factors: smoking, inactivity, metabolic syndrome, all of those things that you're probably very, very familiar with. Those are the causes of it, basically, and it's just lots of little infarcts happening in the brain. And you can see here, there's quite enlarged ventricles, and I mean, this isn't hugely advanced, but there's general neuronal loss as a result of this. So similarly to Alzheimer's disease. And there isn't a treatment for it. Unfortunately, we can't treat a stroke, really. I mean, okay, now you can do all your magic thrombolysis and that sort of thing. But if you've had a stroke and it's kind of happened and it hasn't been intervened with all of those things, you can't repair brain that has died. And it's vascular dementia, the same is true, sadly. It is not treatable. But you can optimize the vascular risk factors if you catch it early and try and prevent it happening worse. So it's kind of, I guess we don't have anything disease modifying for Alzheimer's disease, but in a way, if you really, really manage your vascular risk factors in vascular dementia, you can make much more a difference to the disease progression. But obviously, those risk factors are all quite hard to manage, usually because they're big lifestyle things that are very difficult. Yeah, that's vascular dementia, really. And it presents quite similarly to Alzheimer's, other than the stepwise progression. You get less of a really, really obvious, definite memory loss. Sort of the vascular insults aren't focused kind of in the entorhinal cortex as they are with Alzheimer's disease, but broadly it looks quite similar. And you might have, concurrent stroke things, so neurodeficits as well, all those sorts of things. Right, Lewy body dementia. So who can tell me, let's start with the pathophysiology. What's the pathophysiology of Lewy body dementia? Why does it happen? Maybe it's a tricky question, I don't know. But if anyone can give me any thoughts about what the disease process is like, roughly what might be happening, I'll take any suggestions. Here we go. So protein deposits, excellent, you're absolutely right. Any advances on that? It's cool, no worries. I'll tell you out of your misery. What are the features? That's probably an easier question. Great, hallucinations is one. Obviously it's a dementia, so it'll kind of present with broadly similar symptoms to the other dementias that we've talked about, but any other particular features of Lewy body dementia? Parkinson's, perfect. So Lewy body dementia, what this essentially is it is the same disease process as Parkinson's. It's just kind of happening in different parts of the brain. We've got a few other great suggestions. Cool. You've said it before I even said it. Fluctuating impairment in cognition and attention is absolutely right. And changes in motor function. So you're all spot on there. So Lewy body dementia, as you know, with Parkinson's disease probably, and I haven't really covered Parkinson's disease in this talk, although it is a neurodegenerative disease that often is lumped in with dementias. Parkinson's disease is due to Lewy bodies, which are protein deposits, again, and they particularly happen in the basal ganglia, in the substantia nigra, and those particular areas that you've probably learned about in your neuro lectures, and that leads to the symptoms of Parkinson's disease because it affects dopaminergic transition in that transmission in that area of the brain, and you get the motor symptoms. But Lewy body dementia is basically the same thing happening, but kind of across the whole brain. But actually in Parkinson's that also happens. And the difference between Parkinson's and Lewy body dementia is kind of arbitrary clinical distinction. Basically, if you start developing dementia within a year or before or within a year of developing classic Parkinson's motor symptoms, you call it Lewy body dementia. So even if you starting to develop a bit of, pill rolling tremor, whatever it is, and then 6 months later you start developing, obvious symptoms of dementia, you'd still call that Lewy body dementia. It's only if the dementia has not emerged for an entire year at least after the onset of the first motor symptoms of Parkinson's, then you call it Parkinson's, and it's Parkinson's with dementia. But really, I mean, you can see there's not a very meaningful difference between those two things. It's the same disease process. But these are the particular features of it. And just in terms of, you know, so the way to investigate this as well, actually I haven't put this on the slide, but it's a DAT scan, which is radio-labeled dopamine. So if you are concerned about Lewy body, get DAT scan. So that's cheesy and awful, I do apologise. But this picks up where the brain is using lots of dopamine. So normal brain, there's lots of dopamine. So hang on, so this is not a normal brain. This is Alzheimer's disease, but you can see here dopamine transmission in the basal ganglia is normal, whereas here in the dementia with Lewy bodies, you get it's markedly less in the basal ganglia, but then, you know, in other areas. It kind of looks like it's more in other areas. I think it's a bit confusing, but just remember, you lose this characteristic comma picture. I don't think you'd really have to know that or recognise it from a scan, but you might do in your finals, perhaps. We have a question here. Is this the same as a SPECT scan? It is. Oh, good question. It's not exactly the same because, but it's quite similar. Oh man. So SPECT is positron emission computed tomography. Which works in a similar way, but DAT scan is specifically looking at dopamine. And that's not the full detail of why they're exactly different, but my mind's gone slightly blank. They're not exactly the same, but they're kind of similar. They use radio-labeled isotopes and pick that up. Sorry, that's a bit of a useless answer. Cool, on we go. So that was Lewy body dementia. And then frontotemporal dementia. So I won't give you any prizes for guessing. This is also caused by protein deposits. If anyone knows the name of those protein deposits, I'll be super impressed. But probably the main question about frontotemporal dementia is how it typically presents. So please give me any suggestions about what this typically looks like, frontotemporal dementia. Yeah, I mean, it's a dementia, so same things apply, but there are particular features of frontotemporal dementia, which you can probably figure out from first principles. Yes, personality changes, inappropriate behavior. Any other particular? Pick bodies, wonderful. Well done, Nikhil. That is correct. Those are the name of the protein deposits. They're also tau protein. So frontotemporal dementia is a tauopathy, much like Alzheimer's disease, but it's slightly different. And pick bodies around instead of the flame-shaped ones you get in Alzheimer's. Actually, I think maybe that did come up in my finals. So anyway, remember that, pick bodies, little round things, but they're tau as well. Early onset is quite true. And yeah, personality change, inappropriate behavior, disinhibition, because what do your frontal lobes do? They're kind of to do with thinking, they're to do with, I mean, they do loads of things, but if you have a frontal deficit, and you can think back to Nicholas Gage, the guy with the railway pole embedded in his head, his personality changed, he became disinhibited, and sort of developed, I don't know, I think he did like compulsive gambling and stuff like that. Anyway, disinhibition. So, frontotemporal dementia. Oh, what have I done? Right, so yeah, you saw on the pie chart earlier on, it's a little tiny slice, it's only like less than 5%, I think, of dementias as a whole, but of early onset dementias, it comprises 20%. So typically, well, it often presents earlier than other types of dementia. The reason for that, I don't have enough of a detailed knowledge of the exact pathophysiology to be able to answer that, so apologies, but it just does. And people might know why that is, but I don't. And then in terms of the characteristic features, so yeah, the ones that we've said already, and kind of apathy, emotional blunting, sort of, these are the kind of personality changes you might get. The main thing is, yeah, you've already said it, the disinhibition, the social functioning changes are the big ones. And yeah, that's kind of all I think you need to know about this topic, but please, as I said, ask any other questions that we have. Oh, I think we have someone. What does the higher function mean, please? Is that an obvious question? Good, when did I say that? So higher function is, why is it called that? So I believe you call the cortex, the frontal cortex, kind of higher, so basically it's an evolutionary late part of the brain. So it's something that only very, very advanced mammals have. And that's why it's kind of called higher, if you like. You know, it's thinking, cognition, all of the stuff that the frontal lobes do. Executive, all these clever things that a rat can't do, a dolphin can do more, and a human does best of all, we say. So that's what we mean by higher function, basically. It's not necessarily kind of more important, but it's evolutionary later developed. So on we go. Other dementias. Okay, so anyone suggest there are quite a few, so I don't expect you to get all of them, but can someone give me some different causes of dementia? The next slide is talking about reversible causes. So actually these are other irreversible ones. So CJD, great. That is absolutely correct. Keep a few coming. Normal pressure hydrocephalus, absolutely right. And CJD, just to chat about that while some more suggestions are coming in, is Creutzfeldt-Jakob disease, aka mad cow disease. And it is caused by prions, which are very, very interesting and scary. I'd love to spend more time chatting about them. But basically it's a protein that, well, I'll talk about it in a minute when I have the slide up. Any other suggestions for other dementias? There are a few kind of quite common ones. Huntington's, absolutely right. They're not all kind of curious protein deposit related things like CJD or Huntington's. There are some other things that are like caused by external factors, if that gives you any clues. Neurosyphilis, bang on. Secondary to Wilson's, you're getting the really obscure ones, this is great. And somebody said one earlier, HIV, absolutely, you nearly got all of them now actually. Somebody talked about Korsakoff's, so alcohol-related dementia is another one. Vitamin B, great. You're on fire. Okay, so this is just, a big wordy list of things to kind of be aware of, I suppose. I'm afraid I haven't included any kind of additional detail on these. I'm not sure how much you would need to know, but maybe just check that. So dementia and Parkinson's disease, as we said, basically the same as Lewy body, but it's depending on the timing of the different things. And dementia and Huntington's disease, so that's you get the CAG repeats, which also basically cause a buildup of clumps of CAG repeats and protein, and that causes neuronal cell loss in the same way that the others do. Creutzfeldt-Jakob disease. And this, you might get a question about what this looks like. So it's rapidly progressing. And it kind of, I'm not sure what the typical age of onset is, but certainly, it can have an earlier age of onset. I don't know if it normally does or but anyway, if you have a rapidly progressing dementia, particularly with neurological symptoms, and I think particularly if it's someone you wouldn't expect to have Alzheimer's disease, like a 50-year-old, think about CJD. In terms of how you'd pick that up, has a particular appearance on EEG. There's a particular sort of spike and wave pattern that you get with CJD. And basically it's caused by tau protein, which is just interesting and scary because it acts a bit like a disease, like a transmissible disease, but it's not caused by any kind of living organism, which always, I think, sounds to me almost like the start of some kind of science fiction film. Anyway, but it's a protein that occurs normally in the brain and has a particular configuration, but it can kind of flip into a different shape. I'm trying to think if I have anything. If you have a curved bit of plastic, you could like pop it inside out. It's basically like that. It pops inside, but the thing that the important thing that it does is once it is converted into the different configuration, it then almost catalyzes other of the same protein to pop into that configuration. So then you get a buildup of protein. You get another load of protein deposits, like all of these dementias. But if you just eat some of that protein, it gets into your brain eventually, and it will catalyze your proteins to start doing that. So it's kind of a transmissible disease, if you like. But sort of variant CJD is where it just spontaneously happens. It's pretty rare. So I mean, nothing to be particularly scared of. And there was obviously a huge scare about it, kind of when I was young, certainly, in terms of like beef, and because it was bovine spongiform encephalopathy, it was transmissible to humans. It also happens in sheep. For 1,000,000 points, if anyone knows what CJD in sheep is called, I'll be incredibly impressed. I'll tell you in a minute if nobody knows. Yeah, that's CJD. And then alcohol-related. Scrapie, you're correct. That is what it's called. But it can't be transmitted to humans, so don't worry about it. HIV-related, and I mean, alcohol-related, I mean, these all progress, I guess. I mean, they all present kind of as a dementia with vaguely similar features, but alcohol-related, you might have some features of Wernicke-Korsakoff syndrome, so that's a anterograde amnesia. You can't kind of lay down any new memories, or impaired anterograde memory is what is often a feature of that. And you particularly get confabulation with that, where you, and this isn't a thing that you do deliberately, but because you have holes in your memory, you haven't laid down memories of what's just happened yesterday, your brain just kind of fills in the gaps and you confidently remember that it was this when actually your brain's just made that up for you. So that's one feature of Wernicke-Korsakoff's and to an extent of alcohol-related dementia. Yeah, and all of these, I don't remember ever having to learn any particular details of what these, like, how these present, other than you might see these things in the history. That's the key things, it's the history that you'll pick up these different stuff, or like liver function tests for Wilson disease. So cool, those are the other dementias. And then we have some reversible dementias, which you've already picked up on a few, so I'm just going to press on and tell you what they are. So normal pressure hydrocephalus, which, and this is just a thing that you will, I mean, I have to know this for my multiple choice exams for my MSc Psych, this triad of dementia, ataxia, and urinary incontinence for normal pressure hydrocephalus. So drum that into your head now, it'll save you time later. But that's classically what it looks like. I don't know a great deal about exactly why it happens, to be honest, and it's a bit odd because, yeah, the cerebrospinal fluid pressure is normal if you do like a spinal tap, and yet you clearly have this buildup of fluid with, you know, massively enlarged ventricles. But it is treatable with shunts and what have you to take off, well, I want to say take off the pressure, but it's normal pressure. Anyway, it's treatable is the important thing. So if you see these things, you can treat it. So that's the key thing to know. Hypothyroidism, which we said at the beginning, vitamin B12, neurosyphilis, and pseudo-dementia, which is depression. Well, so it's not as if all depression in older people presents as pseudo-dementia, but depression in older people can sometimes present very much like a dementia. So we'll talk about that on the next slide, but just be aware of these. This is kind of MCQ fodder, really. So depression in the elderly, I mean, depression itself and the features of that, whatever, is a whole other talk, but typically, in general, so this isn't specifically talking about pseudo-dementia. Generally, depression presents kind of similar symptoms, but you tend to have more biological symptoms, so loss of appetite, sleep disruption, that sort of thing. But you do get all the same ordinary features of depression in older people. And I mean, as you can imagine, like those psychosocial factors that we talked about at the beginning, there are lots of things that can push someone into a depressive illness as you get older, sadly. So it's a common problem. But it can look very much like dementia, and I'm going to have to speed up a little bit so we have time to cover delirium. But basically, it looks quite similar, but the differences are the sort of onset and the course of it. Tends to be more rapid, so we're talking like weeks or months, whereas dementia, like it's over sort of 6 months or something. I've noticed my memory is getting worse and worse and worse, that sort of thing. Obviously, you'll have some features of depression itself, usually as well, but the person might not volunteer that, so you kind of have to ask about them, and then you learn about, oh, actually they have all these symptoms of depression. Maybe that's the cause. And also, in terms of how it presents in the clinic room, this is a bit of a soft sign, if you like, but if you're asking someone questions, like orientation questions, can you tell me where we are at the moment, or whatever, or what did you have for breakfast this morning, those kinds of things to test short-term memory. Classically, in dementia and like Alzheimer's disease, someone will not remember, and they'll often like become quite anxious about the fact that they can't remember. Or if you kind of set them a cognitive task like the clock drawing and they can't do it, and it'll almost a really big sign of a dementia in that sort of context is like the anxiety of like trying to do it and not being able to do it, and that's kind of what will happen then. Whereas with pseudo-dementia, you'll tend to get more answers of, I don't know, to like, where are you, what did you have for breakfast, I don't know, and that there won't be that same kind of anxiety about, oh, why, I used to be able to do this thing and now there's a kind of, you know, in dementia, just dropping off of your wanting to kind of engage with the world, I suppose, is a feature. So that's, that's kind of how it can present slightly differently. But broadly, it's just, if you see someone with dementia symptoms, think it might be pseudodementia and look for that in the history. That's all you need to know. Because that's obviously treatable. It's, big take home for pseudodementia. You don't want to be like, oh, sorry, you have dementia, you're just going to gradually decline forever and leave it, maybe give you some rivastigmine. Like, you can treat depression very effectively, so you can completely reverse those symptoms. Right, sorry, I should have opened the polling while I was saying that. So, sorry, I'm always incompetent at this. Right, I have now launched the polling for this question, so hopefully you can all had time to read it. Which of these dementia types is reversible? It's not a hard question. Few more seconds to vote. I'm going to give you a clue. You've all voted for the right answer, so obviously I should. Oh no, someone voted for a different one. Right, okay. So yeah, normal pressure hydrocephalus is reversible. Alcohol-related dementia. Yeah, I can see why one person voted for that, because obviously the effects of alcohol generally, like being intoxicated, do wear off. And, even the effects of alcohol withdrawal and the, delirium tremens that you might get, that is reversible. But alcohol-related dementia, where we're basically, it's a kind of another topic about the disease process of that, but things like, multi-infarcts in the mammillary bodies, where you classically get with Korsakoff's, or in alcohol-related dementia, there's just lots of basically brain damage of various different types due to alcohol poisoning over the years, and that isn't reversible. But by changing someone's alcohol intake, you can probably improve their general level of functioning. So if someone comes to you in a really bad way and they have alcohol-related dementia and they're drinking a lot, you could probably improve the situation by supporting them to stop drinking. But the dementia part of it, like the neurodegeneration that has occurred, is not reversible. So there we go. Right. On we go. Assessment of dementia. So at risk of not overrunning and covering delirium, I'm just going to tell you what these things are. And hopefully you all would have guessed them anyway. So a really careful history is key to tease apart, the timing of this, and that will tell you a lot about what type of dementia this might be and whether it is dementia or not. And really careful history about the support network and what's going on for them socially, because that is so important. You can't separate the whole illness from that. You can do the mental state examination, perhaps looking for visual hallucinations, for instance, that would point you towards Lewy body. That's, a psychotropic, learn how to do a mental state is another thing. Cognitive testing, so MMSE is quite a brief one that you'll all probably do as a med student. RUDAS is a version of the MOCA. Yeah, I think it's the MOCA now that, no, it's the MMSE that is technically copyrighted, so now you have to use MOCA. But they're the same thing, more or less. MOCA is the one that Donald Trump did with the recognizing different animals. What a time to be alive! Yes, RUDAS is a version of MOCA where it's for people who maybe English isn't their first language, or lower educational attainment or something, and it just adjusts it to be more accessible. And ACE3 is a much more in detailed cognitive assessment. It's the Addenbrooke's cognitive assessment. You actually have to be specifically trained to be able to administer this, but it'll give you a lot more information. Basically, all these do is tell you that something's wrong, but that thing could be delirium, or it could be dementia, it could be any different type of dementia. Doesn't give you much information, but it just picks up that something's not right, is more or less what the MOCA does, but it's useful for that reason. And you can compare MOCA scores over time. That's a very useful thing to do. Obviously, physical exams to look for all of this stuff. Blood tests to look for some of those reversible causes. EEG, you don't routinely do, but if you're at all suspecting CJD, you might do an EEG. And you often do brain imaging. Sorry, that should say SPECT, to kind of elucidate the causes exactly, whether it's vascular or Alzheimer's, because you often can't say definitively what it is, and it's useful to know. Right, there we go. Okay, delirium. So listen up for this last 10 minutes of the talk, because this is really important stuff, and is probably more, I should have spent more time on this, because this is actually more useful for the average working doctor. Like, ultimately, dementia is mostly diagnosed and treated in memory clinics. So if you end up working in that setting as a junior doctor, you'll have lots of senior support. Whereas delirium, you will be managing kind of on your own, more on the wards on a night shift as an F1. So you need to know a lot about this. But there's not too much to know, but just make sure you know it. And the skulls are there to remind you how big a factor of mortality delirium is. I mean, quite used to the idea of confused older person coming into hospital, maybe with a UTI, and you're like, oh, fine, cool, whatever, treat that. But like delirium is really important because of how much it increases mortality. I can't remember the exact numbers, but it's big. It's like 50% additional mortality of 2 equivalent patients, one of whom has delirium. It might be 20%, I can't remember. Anyway, it's really important. So we've got enough time, I think, for me to give you a little quiz here on, tell me some features of delirium. What might it look like? Hopefully you've encountered this topic before. If you haven't, now's the time to learn it. So I'll let a few things trickle in of what delirium looks like. I've called it acute brain failure to kind of contrast with chronic brain failure. I mean, that's how I was taught it, and I think that's a useful way to think of what delirium is. It's basically, it's a bit like acute kidney injury. That organ system is temporarily dysfunctioning because of various external factors. But it's reversible. It can go back to functioning normally, although sometimes, occasionally, you might see it might not return fully to baseline. But basically, it's an acute brain failure. And its symptoms, therefore, are quite sort of polymorphic because it's a global toxic insult to the brain, really. Or just, I've lost my train of thought there. But I'll go back to the symptoms now. So we have, you've got some good ones. So confusion is a symptom of delirium, obviously. Hallucinations, absolutely. And you obviously do see visual hallucinations in Lewy body dementia, but delirium is an important one to think about. Agitation, you're quite right. General loss of control. I don't quite know perhaps exactly what you mean by that. But, you're not yourself, I guess. There's a really key feature of delirium, which is like the central feature, which is so important to remember. Does anyone know what that is? It's a bit of a, you're confused, but there's a particular aspect of that confusion. I'm sorry, this is a bit of a reading the examiner's mind kind of question. Oh, you're right, okay, you've got some good ones. That actually wasn't the one I was thinking of, but I'll definitely give you that. The acute onset, so the course of delirium, is a really big clue. If it's come on in a few days, it's not dementia, it's delirium. And the fact that it's fluctuating, which happens to an extent in Lewy body dementia, but is a really obvious feature of delirium. But in terms of, it's a part of the MMSE. It's a part of your 10-item cognitive screen on a clerking performer. One of those, and it's not orientation. One of those is really key to pick up the central feature of delirium, or one of the central features of delirium. Anyone know what it is? Okay, I'll give you a clue. The thing that you're... attention! Hurrah! Yes! Inattention is the feature that I was looking for. Well done, Ola. So, right. Sorry, that was a bit painful. I was just asking you to read my mind now. Okay. Oh, what have I done? So, a really key feature of delirium is inattention. And it's kind of, I guess, a result of the brain is just struggling to maintain its grip on reality. What delirium means in Latin, if you're interested, is going off out of the furrow. It's like a train that's been derailed and it's still chugging along, but it's kind of going off on an odd path. It might crash. But so kind of a lot of cognitive functions might still be working, but some of them are sort of failed. And something that particularly fails in delirium is attention. So if anyone wants to suggest that one item on the MMSE that will pick up that, shout now. And then the other kind of key features of it are that there's a disturbance of consciousness. Oh, counting down from 20, absolutely. So it's the months of the year backwards, it's the serial subtractions from 100, or counting down from 20, those things, where you ask them to do a thing, and then they just have to concentrate and keep on doing that thing, and it takes like a minute. Someone with delirium, someone with dementia might not get it right, or they might get a bit lost and confused, but they'll probably be able to carry on focusing on the task. I mean, unless it's very advanced, then they won't, and very advanced, then they might not. But someone with delirium might start with like December and then think for a bit, and then they've forgotten that you've asked them the question. Like they haven't been able to keep their attention on that task, and it's gone. That's what inattention looks like, and that's a really classic feature of delirium to remember. But there are lots of things. So people have said delusions and hallucinations. That's absolutely right. So someone might like, so a classic, this is a Lilliputian delusion, hallucination. This is from Gulliver's Travel. Lilliput, that was the place he went to where he saw lots of little people. And a classic, although I don't know how common it actually is, a classic feature of delirium is you see lots of little things like little people or little bugs or something crawling up your bed or something like that, is a particular type of visual hallucination that you classically see in delirium. You'll often see people with delirium, or sometimes like picking at the bedclothes, like picking at lint, and they're very confused often if they're that delirious, so you probably can't ask them exactly what it is that they can see, but they might report that there are little bugs or that they're just picking at something. It's called flocculation is the technical name for that, or a carphology, just obscure words to describe that, picking at the bedclothes, but it's a very like classic feature of delirium. But then you also, I guess if you can imagine you're really confused and disoriented and you're seeing things, you're probably going to become quite agitated because you're going to be very scared about what's going on. And that's why people with delirium might become agitated generally. And sometimes you might see like, I don't know, people with guns running onto the ward or loads of bugs everywhere, that sort of thing that would make you directly agitated. But also there's this fluctuation, so you might be like that. Classically at night time, there's this sundowning phenomenon, and that's linked to the disturbance in the circadian rhythm. People will be awake more in the night, and also it's partly to do with the kind of the circadian rhythm and the function of the brain over different times of the day. But it's also just because it's dark, like you're going to be, you've just about been able to keep yourself oriented and reassured yourself that things are normal during the day when it's light, but actually it's dark, you can't see anything, you've forgotten where you are now, and that fear and is kind of enough to tip you even further into delirium. So often people become quite agitated at night. But it affects kind of all aspects, and people can kind of slip in and out of consciousness as well. So kind of become a bit obtunded or sort of go completely unconscious and then come a bit out of it. So that's another feature of delirium. So just be mindful of all these features, because if you see them, that's probably delirium, or at least until proven otherwise, and you need to pick that up and do something about it. You also have these two different types of delirium, which is hyperactive versus hypoactive. So hyperactive is being really agitated. Oh my goodness, I can see stuff, or generally, as you might imagine from the description, hyperactive. Hypoactive is more often missed, and it's kind of more serious because the person is less with it at all. So you're slipping more down the obtunded end of the spectrum, just generally withdrawing, as I think someone commented, just not really, probably might not communicate at all, or might just look at you and maybe struggle to answer any questions. And that generally kind of implies an even worse extent of brain failure, if you like. Okay, so that's what delirium looks like. Now, in terms of what causes it, go. And we've got a couple of minutes left, and that's the end of the talk. I might overrun by about 3 minutes, so apologies for that. But can anyone tell me some causes of delirium? Falls, infection, UTI, sepsis, great. So we've got infection, that's done. Constipation, I'm so glad somebody said that. Spot on, is a really common cause. Post-surgery, for various reasons in terms of pain, which I don't know if anyone's mentioned yet, but pain is a big one. And also the drugs that you get during surgery and generally being disoriented. Electrolyte, oh, perfect. Okay, so you're winning at this. Well done, everybody. These are the causes. Pinch me is a helpful acronym you might use. One of these stupid medical acronyms that's not a real acronym, but anyway. So pain, infection, constipation. And I think these first three, we all know that infection causes delirium, I guess. But often you'll have like confused older person comes into A&E, maybe their CRP is a bit raised. So you're like, oh, they probably have a UTI because their urine dip's a bit funny. And so you treat them for that, and you maybe don't look hard enough for what might actually be causing it, like a broken hip or really severe constipation, which also cause delirium, and like you should do more about than just giving them some nitrofurantoin. So it's really important when you see someone with delirium, they can't give you a history. So get a collateral history and examine them really thoroughly, and including a PR exam, I'm afraid. You know, I mean, that's difficult. The confused person who doesn't even know why they're there. And if you have a really obvious bond or cause, you know, but I mean, it's a good idea to make sure you haven't missed constipation, because that's a very big cause of delirium in the elderly. Partly it's painful, and also it causes a whole load of physiological disturbances, sort of the gut-brain axis, that sort of thing. So don't miss constipation, and obviously don't miss pain, because equally someone might not tell you where they're in pain. They've got a broken hip or whatever have you. And then hydration, which also includes urinary retention, because it's a stupid acronym, much like constipation. Medications, particularly anticholinergics, oxybutynin classically, which is used to treat urinary incontinence. So older people are often on it. The pathophysiology of delirium, basically there's sort of kind of a global toxic insult to the brain, plus or minus underlying cognitive impairment that was there already. And part of that process seems to involve too much acetylcholine, more or less, in particular areas. So anticholinergic, wait, is that right? Yeah. No, sorry, not enough acetylcholine. Dope. Yeah, anticholinergics that sort of block acetylcholine can kind of worsen that process. And there's a parallel here with what we talked about earlier, the acetylcholinesterase inhibitors, which improve memory function by boosting the amount of acetylcholine that's available in the synapse. But various medications like morphine, you know, anything sedating, loads of stuff can contribute to delirium. And also alcohol, which isn't a medication, but remember that. And then electrolyte imbalances. You know, sodium is a common one, calcium less common, but you know, if someone has myeloma, for instance, their calcium might be way off, and that can cause delirium, and also hypoglycemia. And this funny, confusing diagram here, in the last few minutes, is basically, if you imagine these two lines going from mild predispositions to severe, so basically someone down here is you guys with no cognitive impairment, I hope, and someone up here is someone with advanced dementia, who really their cognitive function generally is quite bad as a baseline. And then in terms of precipitants, so down here at the mild end, going into another room, so someone with really advanced dementia, if they just get a bit disorientated, they can kind of almost present a bit delirious just from something really minor like that, or having minor surgery and being a bit of pain, or being constipated can tip them into delirium. However, if someone's cognitive baseline is good, it's going to take a lot more to tip them into delirium. So like encephalitis. And I'll never forget the story of a 65-year-old woman who came into A&E, was delirious, and the medics were like, okay, older woman with confused, right, fine, it's probably UTI. So they stuck her on antibiotics for like 3 days. But the family were all the time being like, this really isn't her. This is so different to normal. You know, I'm really worried. She's not normally like this. It turned out that actually, even though she was 65, there was no cognitive impairment at all. She was cycling to her allotment every day, sharp as a tack. Her cognitive function was great. She was down here. And the medics should have taken that collateral history and taken heed of that, because she had encephalitis, she died. Very sad. Sorry, it's not a story with a happy ending. But in the collateral history, get their cognitive baseline, because if it's good, you might be looking for more serious causes of delirium. I mean, it might still be an infection, but worry about it a bit more. And this is not age, this is just cognitive baseline. So even if someone is 70, they might actually have really good cognitive function. So remember that. Okay, that's delirium, and a very, there's a lot of info on the slide, but essentially, the central thing is to treat the cause of delirium. That's how you manage it. You have to find the cause and treat it, and keep them safe in the meantime. So sometimes people might require sedation, like with haloperidol, if they're really, really agitated and endangering themselves and other people on the ward. That's not treating the delirium really, but it's managing the situation safely until you can treat the delirium by treating what's causing it. So all of these various things that will happen around it, but ultimately you as the doctor need to think, this is delirium, what's causing it, go through your pinch me acronym, find the cause and manage that, and it should improve. So that's really the big take-home message for delirium. And yeah, there's lots of supportive measures that you can use on a ward in terms of helping them be less confused. Because I think if they're already confused and disorientated, that can kind of spiral a little bit into panic, and then they become more delirious as a result, and all of that, and everything's worse. Whereas actually you can help them be less delirious by just helping them feel more comfortable and oriented and reminding them where they are, that sort of thing. So that's really important. Generally, I guess that it'll be more the nurses that are doing that, but it's your job as the doctor to make sure that that's happening on the ward. Okay, and here's just kind of a summary of the differences between delirium and dementia. Hopefully you'll be sent these slides, so I guess I don't need to talk through this really, but I mean, just in brief, obviously the onset, as I said, fluctuating, various different causes of delirium, the fact that it can affect all ages typically, the inattention is a really big feature. Yeah, and these are the things that we kind of talked about. I mean, the treatment for delirium, you can kind of ignore that. It's whatever you need to do to treat the cause of it. So yeah, but hopefully that all makes sense in terms of what we've talked about. So very last little quiz, and then we will finish. Sorry if I've overrun by like 5 minutes. I do apologise. Can anyone tell me? Sorry, I'll relaunch the link in a moment. Okay. So, which of these is not a feature of delirium? I'll give you about 10 more seconds. About half of you voted 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, right. I'm throwing a few slight curveballs here to put you off. So most of you have gone for focal neurological deficit, and you're absolutely right. I mean, if someone's had a stroke, they might then also become delirious because their cognitive function is going to be knocked acutely by that. But that's not a feature of delirium. It might be there and it would give you a clue as to the cause, but it's not a feature of delirium. If you've got cognitive deficit, you're going to be thinking about encephalitis, stroke, various other things. So, and that's why it's really important to do a full neuro exam in someone with delirium. So make sure you don't be scared of the neuro exam. It's fine, really. Just get used to it and it'll all be okay. But get really confident doing those for older people. You really need to, you'll do a lot of neuro exams on older people when you're an F1, and it's really important to get kind of comfortable doing that because it gives you so much information. But a few of you, understandably, have gone for auditory hallucinations because we mainly talked about visual hallucinations. And yes, classically, visual hallucinations are more common, but you do get auditory hallucinations, or hallucinations kind of in any modality in delirium. As I said, it can present in kind of a load of different ways, but the really key features, fluctuating, inattention, clouding of consciousness, and plus all of those other things, but these are like the core ones. Okay, well done everyone. So just to kind of sum up what we've talked about, dementia is a sort of chronic brain failure and delirium is acute brain failure. Generally, apart from the reversible causes of dementia, the treatments improve the symptoms, but they don't change the disease progression. I think one of my PACES/OSCE stations in final year was like drug counselling on someone who was starting a rivastigmine, so I had to remember all that stuff about, you know, the way it'll change the course of disease. So it's all important to know. But yeah, delirium really is the most important thing to take away from this talk. And if, last of all, feel free, I think there was 1 or 2 more questions on the chat, which I will answer now, but please, in the meantime, if you could scan the QR code and give me a little bit of feedback to feed my ever-hungry portfolio. So I have a question, does ipratropium cause delirium? That is a good question. I'm afraid I don't know the answer off the top of my head. And I'm just looking it up, because I'm cheating. Oh, yes, of course, because it is also anticholinergic. So in answer to your question, in my very, very brief and sketchy Google search, which I apologise for not knowing that off the top of my head, does seem to contribute to delirium, yes. If someone comes in delirious and they're on oxybutynin, you might well think about stopping that, because it's not that essential compared to stopping them being delirious. And you could restart it again afterwards if there are several other causes that are going into why they're presenting now with delirium. Yeah, you might be less likely to stop ipratropium, obviously, because I don't know, it's slightly more important to control their asthma. But yeah, it would give you more of a clue. And obviously, if if there's no other causes and that's really contributing to the delirium, then you would stop it. But yeah, please do take this opportunity to ask any last questions. Great. So the histological changes in Alzheimer's are tau aggregation and amyloid buildup. Is there a role of neurofibrillary tangles as well? I'm glad you asked. So neurofibrillary tangles are tau process. That's tau. That's the other name. I don't think I actually described them as that when I was talking about that slide. So apologies. But yes, those flame-shaped blobs that fill up the cell bodies and kill them, that is the tau. That is the neurofibrillary. What a tongue twister. Yeah, they're the same thing. And there's lots more to say, I think, about the pathophysiology of Alzheimer's disease. It's a very interesting area. I just kind of covered the headline bits that you will definitely need to know for like MCQs. All right. Well, hopefully, okay. Please do fill in the feedback if you haven't already. But I hope that was useful. Probably see you again for something else. So goodbye for now. Please leave feedback if you haven't already, and good night.